I want to welcome everybody to the Live Well Kalkaska Substance Free Coalition's Coffee with the Coalition. This is an open and informal discussion about substance use disorders and related topics and concerns within the Kalkaska community in Northern Michigan. Before we welcome our guest speakers, we would like to have everybody attending today introduce themselves. So we're going to start with Katrina.
Hi guys, I'm Katrina. I'm the peer educator coordinator with Michigan Opioid Collaborative, and I'm glad to be able to attend.
Thank you. Angie?
Hi, I am Angie from NFIS. I'm actually interning at Northern Family Intervention Services and also a home-based assistant there as well.
Okay, thank you. John?
Hi, I'm John Supernaw. I am a peer recovery coach with Catholic Human Services in Traverse City.
Okay. Dr. McGram?
Hi, Dave McGram. I'm the part-time medical director of the Northern Michigan Opioid Response Consortium. We cover 25 counties serving Northern Michigan. Nice to be here.
Thanks. And I'm Suzanne Prentice. I'm the coordinator of the Live Well Kalkaska Substance Free Coalition. And next, I want to welcome Tim Hudson, Behavioral Health Consultant for Region 2 of the Michigan Opioid Collaborative, and Dr. Pani Perumalswamy. Did I get it?
You got it.
All right. Associate Professor of Medicine at University of Michigan and the Ann Arbor VA Health System. Today, they will be talking about MOC grant-funded programs with University of Michigan, their goals of bringing awareness to SUD and available treatment options. They will provide an overview of services as well as Hep C in Michigan. And you guys can take it away.
Let me get our slides up. Give me a second here. Always takes me a second. And I have to take it out of this presenting mode. Let's see, duplicate. Can you guys see that okay?
Yes.
Okay. I think Tim wanted to kick this off for us today. But I want to just say thanks for inviting us. And it's so nice to connect with all of you. I've met a couple of you guys previously. Dr. McGram, I think a long time ago, we had a meeting, maybe not so long ago, a year and a half or so. So it's nice to see you again here.
Right, we did.
Yeah, absolutely. First, want to thank everybody for having us here, and Suzanne, thank you for inviting us. And Katrina, as she mentioned, is with our program as well, and we're glad to have Katrina here. She'll be joining us for our monthly coalitions here shortly, but she wanted to join us today so she can meet everybody who is part of the Kalkaska Coalition. But I want to start by just giving some background information on the Michigan Opioid Collaborative for those of you who may not be familiar with us. So we're a grant-funded program funded by the Michigan Department of Health and Human Services and Blue Cross Blue Shield of Michigan with the aim to increase the availability of medications for opioid use disorder treatment in Michigan, as well as bring awareness and education to all substance use disorders. Now, we offer free same-day consultation services to providers for any patients with a substance use disorder. We offer quarterly introduction to buprenorphine trainings, as well as webinars on a variety of educational topics, such as addiction, healthcare, and substance use topics. We provide support for diagnosis, treatment planning, and medication management. We have Pani, who's a hepatologist on staff, who offers Hep C treatment consultations within 48 hours, does a biweekly case consultation. We have the 3-part webinar series on our website that talks about Hep C treatment, and which she's going to talk about more here today. We also have toolkits for providers on our website that discuss things such as alcohol use, stimulants, cannabis, kratom, and polysubstance use. And again, those are all available on our website. We also have webinars on HIV prevention and treatment on chronic pain. We are currently finishing a grant application to expand the work we're doing with HIV as well. And the last thing I wanted to add was just some additional information. I touched on this a little bit earlier. On January 12th of this year, the DEA announced that X waivers are no longer required to prescribe buprenorphine for opioid use disorder. The regulation allows anyone with a DEA-controlled substance license to now prescribe buprenorphine for opioid use disorder. The laws also remove any limits on the number of patients one prescriber can be treating with buprenorphine for opioid use at one time. Now, we are working on some additional language and information regarding this change in the law, which we'll be sending out to everyone within our network here shortly once we have that put together. But with that, I will turn it back over to you, Bonnie.
Okay, that sounds great. Thanks again for everybody for joining. This is really meant to be, let's say, an informal session, but I did prepare some slides just to kind of share what we've been involved in terms of support around Hep C. And I'll just start by saying I've been so really inspired by the providers we are fortunate to be working with in terms of really seeing the treatment capacity around Hep C blossom, I would say, across the state, particularly in rural parts of the state where this is really needed to care for patients living with Hep C. So, we certainly have the tools to solve hepatitis C. We know how to prevent, we know how to diagnose these patients. And we have really effective treatments as of 2014 and beyond. But not everybody has been reached yet, and so there's still a lot of gaps in care. Stigma remains a big barrier, right, for treatment. And unfortunately, discrimination around Hep C and is real. And I think this is really where working with frontline providers in the community becomes, very important. And so what I wanted to just highlight is what is going on with Hep C, and a lot has evolved in the last couple of years here in Michigan. And I would just always keep in the back of my mind, what are our opportunities to continue to advocate so that we can increase the reach to support people living with hepatitis C better. So obviously the Michigan Department of Health and Human Services puts out an annual surveillance report, and the report is focused on not just Hep C, but Hep B, liver cancer. They also include some information about hepatitis A, I believe, in that report. But the large focus is on Hep C and Hep B. And so this is data from the 2021 report. And as you can see, the graphic on the left, the darker shaded areas in purple represent higher rates by county in terms of the number of people living with hepatitis C per 100,000 persons. And the graphic on the right specifically looks at adults under the age of 40, where we've really seen most of the increases in new infections in people living with hepatitis C. And you can see how certainly parts of northern Michigan and the Upper Peninsula are among the geographic locations. We have a lot of patients living with hepatitis C. Hepatitis C testing recommendations were revised in 2020. Some of this actually coincided with the start of the pandemic, really in March of 2020. And screening got expanded. So prior to this, screening was risk-based, and we know going back through the literature and through the Institute of Medicine report that was put out on viral hepatitis and liver cancer back in 2010, the risk-based approach was very problematic because we weren't doing a good job as providers of asking patients about risk. Patients were not always wanting to disclose risk. And when they did disclose risk factors that, might put them at risk for hepatitis C, a lot of providers didn't know that that should prompt hep C testing. So, that risk-based strategy, which is what we had in place for a very long time up until 2020, really missed a lot of patients living with hepatitis C. So so based on additional studies that were done in the context of knowing that we were likely underdiagnosing people, they kind of re-looked at national data, NHANES and others, to see where were the kind of populations that had the highest amount of hep C, and they tried to look at this really from an age-based approach. And then that got evolved over time then to this now all testing all adults at least once in their lifetime, which is where we are at. It's also recommended we test all pregnant women during each pregnancy. There's one like a little side note, the exceptions to doing testing is in places where the prevalence of hep C infection might be less than 0.1%. And then in all persons with risk factors, so injection drug use included, these patients should be offered periodic testing while the risk factors might be ongoing. And this is where it's a little open. The AASLD IDSA guidance is to consider testing every 6 to 12 months in people with ongoing risk. And really, the testing recommendations highlighted that any person who's asking to be tested for hep C should receive it regardless of, inquiring about risk, disclosure of risk, because many people might be really reluctant to disclose risks, which are unfortunately very stigmatized. And the USPSTF obviously has now given this also a grade B recommendation, which is very important for adoption and reimbursement, particularly in primary care settings. And we know that, again, since really 2014, we've made even further advances in terms of how do we think about simplifying treatment for most patients. Certainly every person living with hepatitis C, it's recommended they're evaluated for treatment, and this is in the AASLD IDSA guidances. Direct-acting antivirals in the United States are actually approved down to the age of 3 years of age. And one, significant gap that still exists is that direct-acting antiviral therapy is not yet approved in pregnant women. And remember, we've seen large increases in new hep C infections in people under the age of 40. And so this includes women of childbearing age. So this remains an important group in which not just are there now testing recommendations, there's still a treatment gap to say we can safely give this. Now, hep C infection, in pregnant women should be considered a biomarker really for opioid use disorder, many have argued, and that opioid use disorder treatment is indicated for women who are pregnant with ongoing, opioid use disorder. There has been one phase 1 study. I've given, I've included this in many talks over the years, and to me, it's just so striking how little we've been able to move the needle. But there's been one very small phase 1 study of 10 pregnant women who were treated with ledipasvir sibosavir during their 3rd trimester. All of the women were cured of hep C. None of the babies acquired hep C. But we still don't have a lot of safety data. Now, the AASLD IDSA guidance now leaves it somewhat open for providers to discuss and make decisions in conjunction with patients as appropriate. But I would say that most, providers are not doing treatment in pregnancy because of the lack of safety data, and there's inadequate safety data in breastfeeding as well. There is a registry, a global registry, to try to collect cases of women who become pregnant on treatment to try to ascertain some safety data that way. And some of that data is actually might get presented this week at the Global Viral Hepatitis Summit that's going on this week in Paris. So I think we'll learn more soon. But treatment itself, certainly we have to confirm after the screening test for hep C infection is an antibody test. If that's positive, then we recommend to have reflex confirmatory RNA testing, which unfortunately hasn't been realized yet widely in Michigan, as in other places. So that's where you basically draw enough blood to run both tests so that patients don't have to come back in between each of these steps, because we lose patients the more steps we put them through. But after they have confirmed virus through their RNA PCR, we do a very kind of basic, I would say, assessment of like history exam and labs. And, you know, the treatment for Hep C is now what we call pan-genotypic. So Hep C has many different subtypes. And we used to have to figure out which treatment and how long to give treatment based on the subtypes. And we don't have to do that anymore, because these newer treatments treat all of those subtypes fairly well for most patients. So for your never been treated before, no cirrhosis patients, we don't have to check the genotype. Now, some providers still prefer to do that, to know that if they get reinfected, is this really reinfection versus the virus not getting cleared the first time. I think the most important thing for patients is still to assess for how much fibrosis they have. And the really important thing is just to know, do they have cirrhosis before you do treatment or not? And it's not so much because we don't treat patients with cirrhosis. We actually do. That's the best thing we can do to stabilize their cirrhosis as well as reduce their risk of liver cancer. But it's important to know if they have cirrhosis before we do their treatment, because after treatment, after cure, which is still the best thing we can do to stabilize their liver disease and decrease risk, there is still some risk around developing liver cancer, developing varices, or decompensating from liver disease. So those patients, even after they're cured, will need some monitoring lifelong. There are some studies right now trying to understand, can we better identify the patients who may not ever develop a liver cancer after we cure them of a Hep C? So I think this space is evolving, and we'll probably see some more precision medicine type of information to guide, you know, who do we have to continue to do like liver cancer screening on. Another important step is to look for drug-drug interactions, and there are now like online tools to do that. If you're not using an electronic health record, for example, that can't do it. I often use the Liverpool drug-drug interaction check that's widely available, open source. You know, obviously the two pan-genotypic first-line treatment for treatment-naive non-cirrhotic patients are sofpilbatasphere, which is 1 tablet once a day with or without food for 12 weeks, or glisepivir pibrenizumab, which is 3 tabs that you take together with food, typically for most patients for 8 weeks. And Michigan Medicaid, prior to the release of their Hep C elimination plan in April of 2021, actually had the pharmaceutical companies compete to basically be the preferred regimen. And the preferred regimen for Michigan Medicaid patients is the glisepivir pibrenizumab regimen, based on that competition that Michigan Medicaid had with the companies. Now, I just mentioned that curing Hep C is important for all of these patients, including those with very advanced scarring or what we call cirrhosis. Most of our younger patients do not have cirrhosis. So again, when we're talking about a lot of the people that you might be seeing, or the providers you might be working with who are seeing patients, many of them have young patients living with Hep C. And many of these patients don't have cirrhosis, mostly because they haven't had it long enough to develop cirrhosis, but they still do need an assessment. A lot of these assessments can be done non-invasively just by looking at blood tests and trying to assess, are they low risk or high risk for cirrhosis? So one such test that we commonly use is the FIB-4 test. It's just based on your age, your platelets, your AST, and your ALT liver enzymes. And why it's important still to do this, and I think this is like, I know I reinforced it on the last slide, but I'm taking an extra minute to do it here, is that, you know, liver cancer risk does persist, although it decreases quite dramatically with a cure. It doesn't go to zero as if you never had cirrhosis or liver disease. And it can also, and what we know is that the FIB-4 has also been looked at in terms of for who this improves after treatment versus for those who it stays elevated after treatment. And we know that risk stratification can kind of be done based on whether or not that FIB4 improves, so your non-invasive fibrosis test. Now, reinfection is something we have to always counsel patients on if there's ongoing risk factors or exposures. And in those patients where there is ongoing risk, you can still talk to them about the timing of treatment and monitor them for reinfection. I think the important thing there is also to reinforce harm reduction strategies, access to syringe services programs or other harm reduction efforts will be really important to reducing their risk of reinfection. And then counseling patients that they'll be Hep C positive lifelong is a really important thing. So, and that does not mean that it's just basically it's a footprint that's left behind in our body saying that you've had Hep C, but the most important thing is making sure that the RNA is cleared after treatment. And if that's gone for 12 weeks after treatment, then you're cured. So what we've seen since these new treatments became available in 2014, and this is data from the CDC, you can see that in that first year that these new medications became available, we had this pretty significant increase, right, in the number of scripts that were written for Hep C direct-acting antivirals. So from 100,000 up to 160,000. And then you can see we've had kind of a steady decline since then, all the way up to 2020. And some of the drops in 2020, the CDC and other agencies think is in part related to COVID, decreasing testing and treatment in that setting. But in 2015, the National Academies of Science and Medicine tried to do some modeling estimates to say, okay, in order for us to achieve elimination by the year 2030, which is what WHO and in the United States we've kind of accepted as our goal, right, or something to aspire to in terms of eliminating Hep C, they estimated that we would need to be at least curing 260,000 people a year in order to achieve elimination by 2030. So you can see, nowhere in the last 6-7 years have we reached that number. So I think it again just reinforces that the United States, along with many other countries, are not on track to achieve elimination by 2030. There are some countries that do seem like they're on track, and that's really because of the national plan and funding behind the national plan. The healthcare systems are a little different. There's some countries where you can write the script for Hep C treatment and the patient goes right to the pharmacy and picks it up the same day and starts. So the models for treatment are really different and country specific and really heavily influenced by what resources have been allocated to support this. And then in August of last year, the CDC kind of had a vital signs report that they put out where they looked at Hep C infected patients and timing to start treatment. So dark blue represents starting Hep C treatment in the first 6 months of their diagnosis. The light blue area indicates starting treatment in the 6 to 12 months after their diagnosis. And then they looked at insurance type. And you can see we have some disparities, right, in terms of Hep C treatment based on insurance here. And I think the most important thing in my eyes is just like how many people, which I've put in red at the top of this graphic, are not treated, right? We're talking about 77 to down to 65% of people who are newly diagnosed not getting treated. So still a major gap there. Now, as I just mentioned, in April of 2021, Michigan MDHHS Viral Hepatitis Unit, in conjunction with Michigan Medicaid, launched the state's Hep C elimination program. And we actually have one of the best kind of policies in place to support Hep C access to treatment from the Medicaid standpoint. So the Center for Health Law and Policy Innovation at Harvard and the National Viral Hepatitis Roundtable actually several years ago started issuing basically report cards to each state's Medicaid program as it relates to Hep C treatment access. As of last year, because we have removed all of the restrictions, around treatment for Hep C. So we used to have a lot of restrictions around needing to have a certain level of fibrosis, needing to be a certain provider type, making sure patients were abstinent from alcohol and drug use for 6 or 12 months. And all of these things actually presented really barriers to treatment. And Michigan has now eliminated all of those barriers in their process. Okay. So Michigan Opioid Collaborative in 2020 actually integrated Hep C support services into our program. So this was really predating, right, the launch of the Hep C elimination plan in Michigan. This is data in 2022. We had at least 18, case conferences. So these are held every other week around Hep C. But you can see kind of how this is really folded into a larger effort of the Michigan Opioid Collaborative, which really provides a lot of 440 plus trainings across the state. We get really good feedback from colleagues who participate in our programs, a high number of webinar, attendees over the last year, and a number of webinars, and I just mentioned the Hep C webinars as well at the beginning. And then a lot of outreach encounters that our behavioral health consultants do in conjunction with other members of the team. Now, kind of additional impacts of the Michigan Opioid Collaborative include roundtables that are held, 30 plus roundtables in the last year, I believe, with over 700 attendees. This is really intended to bring frontline community providers together to really touch on trending or important topics in substance use and medications for addiction treatment, and to really also have a space for us to discuss, barriers and share what available resources look like within the community. And so some of these roundtables now are statewide and focused in the perinatal kind of space, where we still are seeing a lot of gaps and need to kind of come together to really address this need. And there's an Eaton Rapids Medical Center opens their first opioid use disorder treatment clinic. There's in Region 4, and you can see highlighted there on the map, there's a local behavioral health consultant providing support and technical assistance for Eaton Rapids Medical Center since, I think, October of 2022. So I think this is exciting. We're always looking again to see how we can better support providers across the state. And, certainly these are total consults. I think I've done at least like 4 or 5 this month, for example, in Hep C. So providers can reach out to me directly via email. There's no patient identifiers on the forms, and we can talk about kind of any parts of treatment. There's like a templated form that just reminds providers what labs to check and how to do a fibrosis assessment. I'm always happy to review those cases. And as Tim said at the beginning, I try to do that within 24 to 48 hours and get it back to providers. And then providers are always welcome to come to our every other week, Hep C case consultation program. But again, you can see that there's other consultative opportunities for polysubstance patients, chronic pain, great moms, for those providers seeking maternal opioid use disorder support, and a variety of other topics. I think this is like some feedback we've received that we wanted to share. So this is like a quote we thought we would put out there. So as a physician in private practice, help from the Michigan Opioid Collaborative has been essential. I've called 3 times with difficult or unusual situations, each time getting advice the same day. One was paradoxical side effects with buprenorphine, and the physician was able to guide me towards a product with different bioavailability that worked perfectly for the client. And the other 2 times were more behavioral issues with clients with extreme trauma. Each time I was treated with great respect. I felt extremely comfortable getting advice from providers who know how difficult it can be to know the right thing to do for patients who are suffering. These clients need compassion, but also boundaries and support. I'm so thankful that I can provide this care in a primary care setting, caring for all the client's needs with the help of experts to guide me when I get out of my comfort zone. And I think we've heard certainly similar feedback from the Hep C program. I think certainly, as I said, we started in October of 2020, and we provide direct case review. This actually was a requirement, unfortunately. They needed a specialty, Hep C provider on the prior authorization prior to April of 2021. They no longer need that. This is all like optional and really trying to tailor it around what providers in the community might need to help really expand their treatment capacity. So we typically, for new providers, they always welcome to reach out. Audrey Jackson's been our point of contact, but people can reach out to me as well. And then we usually will set up a one-time meeting just to talk about how we can really tailor the support to the provider. And then reviewing cases, and every other Friday, 9 to 10 o'clock, we meet with providers, and anybody's welcome to drop in. And Katrina has been a really nice addition to this group as well. The first 6 months of doing this work, so our providers, several of them were in the Upper Peninsula. I think the thing that's really blown my mind is that now the 3 initial providers we started working with in the Upper Peninsula have trained additional providers. So they are actually growing treatment capacity amongst the provider community, amongst themselves, which I just think is like so amazing. So in the first 6 months of this program, we had, close to 50 cases that were reviewed. And I think one barrier we've seen pretty consistently since the start of this program is justice involvement with people living with Hep C. So even though a lot of them started treatment, of those cases we reviewed, and more than half of them achieved a cure, one major kind of barrier was interruptions in treatment in people who went to jail while they were on treatment, or they were about to start treatment and then they ended up in jail. So then there was a delay in start. And then the third barrier I would say we've seen is like people ending up in jail and we don't know if they're cured or not because they completed their course of treatment. So I think, oops, sorry about that. And like I said, a lot of these providers are just doing some incredible work to expand the capacity locally amongst their other providers. So one family physician up in Escanaba has trained another peds physician in the Upper Peninsula. A nurse practitioner at Great Lakes Recovery Center has trained another provider locally. And then one physician at the Alcona Health Center has now trained another provider in their FQHC system. Sorry, my slides are, okay. So I spent a lot of time just really thinking about rethinking the role of specialists and how do we be really in a supportive role rather than a primary role. How do we simplify our guidance to increase adoption and adherence and make it easier for people to offer Hep C treatment? And I think there are still some training gaps that we can help fill. So I think this is where specialists can still, be supportive and helpful. Getting patients treated remains a common goal. Really rethinking how Hep C care can be a low barrier or low threshold care like we do and tend to think about opioid use disorder care. And really realizing that Hep C is just one piece to a larger, more complex picture, particularly with the rise of opioid use disorder and other infectious related complications that we are certainly seeing. And then thinking about how we can continue to advocate in this space and advocate for more funding and more support so that we can increase the reach and access to treatment. I think that's all I had.
Thank you. That was a lot of information. Does anybody have any questions?
I do.
Okay.
So Pani, I'm trying to figure out the lay of the land in northern Michigan. You've got a couple of healthcare systems. Actually, you got 4 healthcare systems. And So tell me about the average patient that might be seen by a McLaren healthcare provider, say in Emmett County or Sheboygan County. I don't know, do they have infectious disease specialists there that they lean on, or are they treating them at the point of care? What can you tell me about that system?
You know, I don't know about that system. So most of the providers I've worked with, let me just start maybe there and can kind of share those. So a lot of the providers I've been working with are either through an FQHC system. So in Northern Michigan, I've worked with Thunder Bay, Alcona Health System, which is, I think they have 13 facilities across northern, eastern, and western parts of the state. The site near Alpena is the one that started Hep C treatment. They're very interested to grow, right, capacity to the other sites across the state. And then the other programs, and we actually just had a roundtable discussion last week with some of the Upper Peninsula and these northern tip kind of providers. Great Lakes Recovery Center, there's a family, so they're also a multi-center kind of, I would say practice of sorts, but there's one NP who really took on Hep C treatment back in 2020 and then trained another provider in the system. So they're able to offer it at more than one location now that they have. There's a family medicine provider out in Escanaba who, the way she got into Hep C treatment was her local GI doctor in 2021 was retiring. And she said, who's going to treat my patients? And he said, how about you learn it? And then she connected with us and she learned it. And now they've trained another provider, a MedPeds provider locally as well. And then I just very recently started connecting with another provider who's, I think, closer to Marquette. His name's Greg Jones, and he's working at a small community health center, federally qualified health center, I believe. And he started doing some Hep C treatment. So you can see that most of the providers we've worked with, I wouldn't describe all of these centers as small, but some of them are smaller kind of practice or group practices, but some are in these kind of FQHCs, and they're trying to figure out how they can scale it even within their systems. So I don't know as much though about the health system you just mentioned. I don't know, Tim, if you have any information. Nothing comes to my
had a
mind.
ton of success with connecting with McLaren as we have Alcona and say Monson, for example, in this region. I believe McLaren has some infectious disease docs there that they are working with, but I'm not 100% certain. We just haven't had as much success there with our outreach efforts.
So, and let's talk about Munson for a minute, because it seems like a couple of years ago, Suzanne or Tim or the two of you facilitated a discussion, and Ani, you might have been at it too, about the kind of the explosion. And I can't remember if it was HIV or HCV in Kalkaska County. And I think getting back to your slides, I think it was because people were now getting tested that weren't getting tested during COVID. I think some of the providers in Kalkaska stepped up to help with treatment, but I'm not exactly sure. There's infectious disease specialists in Traverse City, and my sense is a lot of times people will defer and just send people for treatment where there's a higher volume done. So you've got infectious disease in Traverse City, and you've got Thomas Judd in Traverse City. But
Right.
Do any of you know what the latest is in Kalkaska itself as far as treatment on site in town, or how we're doing with HCV and HIV?
So my understanding, still primarily just in Northern Michigan in general, most people are being sent to Thomas Judd for treatment, which is something obviously that's one of the goals of one of the things we're doing with integrating some HIV prevention into what we're doing is to kind of move away from that and kind of having it all be at your central location through your PCP as some of those prevention efforts and ways that we're not sending people 2 hours away to receive that treatment at say like a Thomas Judd. But as far as I know, that's still kind of the case. I don't know, Suzanne, if you've heard differently or seen differently.
Yeah,
But I know that's
I'm not sure. I'm not sure, but I can find out. I can find out what we're doing. I know a few years back, before the stipulations, all the stipulations, we did have someone in Kalkaska that was treating it, but he's gone. I'm not sure what they're doing now, but like I said, I can find out.
You know, we've got sort of the middle of the state with Gaylord and Grayling, and those are Munson Healthcare. I don't know if there are providers in those communities that are treating folks. I'll ask around.
the last time I spoke with somebody at Thomas Judd, and it's been some time now, it's been several months. They said, you know, it wasn't uncommon for them to still get patients from even the Gaylord area, you know, a couple hours away. So it sounds like that's still probably a common practice.
And,
That's a long ways to travel.
And
Yeah.
David, you know, we actually have so there's a quarterly Hep C clinical collaborative call. It actually happens to be this afternoon. I'm happy to ask. So obviously MOC provides Hep C, you know, support, but there are other programs that are working with providers in different capacities. So I think the state has funded like a telephone line through Henry Ford to support Hep C treatment questions from providers just across the state. And the Maytech group through Wayne State, they've been very focused in efforts in, I think, around Wayne and then also in the Upper Peninsula. So they've been doing some work with tribal communities. I'm happy to ask about it on the call to see, you know, if the viral hep unit knows kind of what's happening in the treatment space there this afternoon when I meet with them to get a better sense if some of the other groups, right, supporting Hep C in this space is connecting with people or providers geographically in that location.
I'd appreciate that. Thank you.
Yeah.
Any other questions from anybody? I've got a
And
question.
David, if you feel like there are other ways for us to connect or get the word out about working with providers that you think would be helpful, we're always open to hearing that. Certainly, we always put the Hep C services into like the newsletters that go out to all of the providers. But you know, some providers I don't think necessarily always look at that or read all of the details in it. So if there are specific you know, ways, you know, you'd like us or to explore to try to reach more providers to let them know that there are like supportive things, we're happy to do that.
Thank you. I'm meeting intermittently with some of the chief medical officers around the region. So I'm going to be meeting this month with Dr. Nuravedla, who works for Munson Healthcare and covers Gaylord, Grayling, and Charlevoix. So I'm going to put this on my list of things to speak with him about.
Sounds
And I
good.
also meet with some physicians at McLaren and Petoskey. And as mentioned, they have ID specialists, but I think they've got a bunch of employed physicians in Sheboygan. So I'll see what I can find out there as well.
Yeah, you know, the Thunder Bay group, I think they got interested. They built it into their HIV treatment kind of process and program. They had initially some patients who were co-infected, but then they were just seeing some mono-infected Hep C patients. So they were able to, you know, their ID docs there wanted to learn, and family medicine also like wanted to learn a little bit more about how to build capacity. And we had worked with them and sounded like that was going, and they were actually seeing some, you know, over the age of 45, a little, you know, more fibrosis, kind of patients with a little bit more advanced liver disease. None of them were like decompensated cirrhotics or anything like that. And then the other thing that's happening in the space is that the local county health departments, some of them, and I'm trying to get a better understanding of which ones and to what extent. Is it just testing? Some of them are actually doing treatment So we've just like I just got a list of the counties that are offering that. I didn't see that Kalkaska County was on there, but I'll double check it. But they are trying to work with local county health departments to also be able to offer more than just information, but actual testing and treatment, which I think is really great.
Angie's got her
Yeah,
hand up.
I forget about the health departments, but yes. And I even wonder whether Harm Reduction Michigan is doing some treatment at some of their sites. I know they do a lot of testing and they're doing MAT through some of their mobile sites, and I know their Cadillac site is doing MAT, but yeah, they may be also doing some hepatitis C treatment.
Angie?
Yeah,
Yes. So I'm contracted through DHHS and CMH for my program. So the community mental health and the Department of Human Services. Do you guys partner with the Department of Human Services to provide information services?
meaning MDHHS, the Michigan Department of Health and Human Services. Yeah.
Yes. Yeah, correct.
So they have, I think they have our support services linked on their website. They have, I think I would say more like resources on their website. So one thing that the We Treat Hep C Clinical Collaborative, one of the ideas we had was to kind of work with them to create a Hep C provider directory. You'll see that on the MDHH website, which is a nice way, David, if you didn't also and others know about it, a good way to link patients, right, to providers who are doing Hep C. So one thing to do might be to actually look at that map now that I'm just talking about it, and look at, if there are providers in Kalkaska County listed in that directory. So Angie, I would say there are more resources on the MDHHS website. Our goal was never to duplicate great resources that are already out there. But there are some unique things that are on the MDHH website. They also have information about the Henry Ford Warm Line. They have some information about the Maytech program because the Viral Hep Unit is funding those programs. And I know our program's listed on there. And then there's also obviously all their surveillance data, some of which I presented, but a lot more on their website. And then they do have some patient-centered, I think, resources as well on their website around Hep C. If you go to the Viral Hep Unit, and there's some, so I would say definitely take a look at their website, but they have additional things. I think the Hep C Clinical Collaborative has just created a space for all of the people doing some supportive work in this space to come together and share what it is that we're doing. So we actually meet quarterly. And there is more than one thing going on, and I think we're all in agreement this is a really great thing, because location and connections and all of these things are a little different, like provider by provider, geography by county by county. So I think we're just feeling like the more that we have to offer, the better that is overall, because there's just so many people that we haven't reached yet, and providers that are seeing these patients.
Yeah, thank you. Yeah, I'll check that out.
I will say that there's some data also. I think there's a syringe services report on the MDHH website. There is a very small amount of, I describe it as a small amount because in relation to the amount of people accessing syringe services, there's a little bit of Hep C and HIV testing that's happening. I still think that's an area where if we had more resources, it would be great. I think additional resources could also support doing more with jails. And so we're right now, we actually have a meeting right after this. We've been having just some biweekly meetings to figure out how we could address some barriers with justice involvement, because leading to an interruption in treatment is just it feels devastating. It's not in line with trying to get people eliminated and for a Hep C and cured, and getting rid of Hep C in our state. So I just feel but the jails are very privatized, so that is a major barrier, I would say, but we're trying to have some discussions to understand, are there ways we can work with local county health departments and jails, to offer testing and linkage to care, or, what is possible. So I think we don't know the answers yet, but we're hoping to do more work in that area.
What about MD, Michigan Department of Corrections? Is there?
So yeah,
Those are
Department
longer
of Corrections.
stays.
Yeah, the longer, so the largest, the prison system does have a Hep C treatment program. I think it's the Prairie Health oversees one of the largest prisons here. Craig Hutchinson is an infectious disease provider who oversees Hep C. He's been very committed to getting people treated and cured while in prison. There are some limitations from my understanding of the budget. So the annual budget basically allows them to treat 500 patients with Hep C annually. The problem is they have at any one time close to double that number of people living with Hep C. So they do try to prioritize patients, who are older, more fibrosis, and they are doing treatment. So I think if they had more support and, that certainly could be an area we would hope to see expanded at some point in the future, because it sounds like that remains a need and time course is defined. I will say that there are some other treatment models for doing this in jail, though, too, in other parts of the United States. But the linkage to care has to be really strong. It needs to be supported with resources. I think a lot of jails are not incentivized to be thinking about the medical. And I think Hep C is just one of the issues. The bigger issue is also opioid use disorder and access to treatment in that space, right?
Yep.
So we're trying to piggyback those discussions, if you will, and trying to explore, how we could address this. How do we address needs around opioid use disorder, Hep C, other, you know what I mean? As part of kind of the larger, just picture of a patient. Yeah.
Yeah.
Isn't part of the challenge your Medicaid coverage drops when
Yeah.
you're in jail?
Yeah. So
you gotta have
with
the money.
HIV, there's a waiver, right? And the waiver then covers, I think, for some coverage around treatment to stay in place, I think. We don't have something like that for Hep C. We have been told there's a lag time in which that happens. So it really would take a lot of dollars. Just to be frank, to support treatment in jails. Because we don't have the other policies in place to enable it to continue. Yeah.
So ballpark me a dollar amount to treat a patient with HCV.
Yeah, so the cost has come down, but it's still crazy expensive. So it's $50,000 a patient at least. This is down from $80,000 to $100,000, which is even more absurdly ridiculous. So now the companies, because I've asked this question, so they do have a pricing program for corrections. They have a whole arm, but it's still crazy expensive, I think. So this is where all of the access issues start with, okay? The pricing of these drugs, there's no mistake about that. It's because they're so expensive that payers don't want to cover it. And they created all of these restrictions, actually, in fact, all of the restrictions were put in place because of the high cost of this. And payers were trying to figure out, how do we, do treatment for the people who really need it first. But then the argument was, well, they all need it. You're trying to prevent cirrhosis. So you actually don't want to wait till they get cirrhosis to do treatment. You want to try to, get to them earlier. So I think that space has evolved because of this policy stuff that, NBRH and the Center for Law and Healthcare Innovation Policy at Harvard have done with the report cards has increased. It doesn't look good if your state's Michigan Access Program has got a grade D compared to a lot of states that have an A, but there still are a lot of restrictions to access to the treatment, and it's driven by price. Yeah. Very unfortunate. It's so crazy. You know what the cost of these treatments through generic pricing is abroad? I think Chai had put out a report detailing some of this. You can do testing for $2. You can do a whole course of treatment for $150, you know, which is still a lot of money in like low and middle income countries, which is where they've been able to price with generics really low. But for perspective, right? Like it's so crazy that yeah, pricing is this way and it could be really another way. It's a bigger problem. Yeah. But in Rwanda, you can get treated for less than $100, like, you know, $150. It's so wild.
Seems like the United States should be able to provide, you know, this treatment for a minimal cost.
That would be really nice. You know, in Australia, that was like one of the countries where you can write this script because they funded a national you know, the problem is the White House is now going to come out with this elimination plan that will probably have some dollars finally behind it. But, you know, Hep C is still very underfunded. It all comes out of communicable diseases, and most of that goes to HIV, right? And much less comes to Hep C, much even less goes to Hep B. There's been a little bit more funding nationally through like opioid use kind of disorder focused, you know, support programs, but still not enough. You know, advocates keep asking that we need more, you know, in the fiscal budget. So yeah, but the countries that are on track have just like put a lot of dollars behind, yeah, supporting this and committing to it.
Awesome, thanks. Anybody else have any other questions? No? Okay, well, I want to thank Tim and Connie for being here and giving us this great information.